Hello, I'm Dr. Jeff Curtis, professor of medicine at the University of Alabama at Birmingham. I'm excited to bring you an expert panel of people who are our colleagues, but really have a lot of great insights into a very hot topic that really concerns all practicing rheumatologists, and that is the safety of the Janus kinase inhibitors, especially for patients with rheumatoid arthritis. Some recent safety trial results were presented at the ACR 2021 Convergence meeting, and that's the topic of the next several minutes to have a roundtable with a number of my colleagues around the country. Let me have them introduce themselves now.
Hi, I'm Christina Charles-Schoeman. I'm a professor and division chief at the University of California in Los Angeles.
Hi, I'm Alan Matsumoto. I'm a rheumatologist in private practice outside of Washington, D.C.
And hi, I'm John Giles. I'm an associate professor of medicine at Columbia University in New York City.
Well, thank you all. And this is very much an august panel of people who have really devoted a great deal of time thinking about how some of the recent study results that we have only had hints of that were presented in much more complete detail in the last week or two have unveiled a lot of new thoughts and perhaps some impact on practice that we're getting ready to share and lend some of our experience and opinions about. So maybe, Christina, I'll ask you to get started. A lot of what's caused a great deal of controversy at times, and certainly a lot of discussion, relates to Pfizer's recently published safety trial, the oral surveillance trial. Can you give us a little bit of background context about what exactly that is, and then maybe speak to some of the early results, especially around venous thromboembolism, that caused some concern with the trial's Data Safety Monitoring Board?
Absolutely. Oral surveillance was a randomized open-label non-inferiority phase 3b/4 safety study that assessed the relative risk of major adverse cardiovascular events, or MACE, and malignancies with tofacitinib 5 or 10 BID compared to TNF inhibition, patients with active, moderate to severe RA despite methotrexate treatment. All patients in the study had an increased risk of MACE. They were greater than or equal to 50 years of age, and they had at least one additional cardiovascular risk factor. And in 2019, a review by the DSMB noted a statistically and clinically important difference in the frequency of PE with tofacitinib 10 BID compared to the TNF inhibitor group. An increase in mortality with tofacitinib 10 BID versus the 5 BID group, as well as TNF inhibitor group, was also noted. And so for the remainder of oral surveillance, all patients randomized to 10 BID of tofacitinib were then reduced to 5 milligrams BID of tofacitinib.
Well, thank you. And I think that that caused a great deal of speculation on how the trial's main endpoints of both malignancy and MACE events would play out. John, maybe you can tell us a little bit more about a non-inferiority study design, something that we don't think about a lot and come across often in rheumatology, and how that impacted the MACE results, and kind of how you're thinking about messaging that in an effective way as to the primary results of the study.
Right. It's a concept that's a little bit hard to convey to the lay public. So the study is based on a non-inferiority margin, which is pre-specified. And this particular trial, the margin was set at 1.8, meaning that the upper bound of the 95% confidence interval for the hazard ratio for the comparison between tofacitinib and TNF inhibitors for both the two primary endpoints, which were major adverse cardiovascular events, and for malignancy, the 95% upper bound of the 95% confidence interval could not go above that inferiority margin. Now, to bring that back into sort of lay terms, it means that the true difference between the two groups could not be above a 1.8 times higher for the tofacitinib group. So when the conclusions of the trial, the point estimate for the difference between the tofacitinib group and the TNF inhibitor group was 1.24 times higher for tofacitinib compared to the TNF inhibitor group. But the upper bound of the 95% confidence interval was actually above the 1.8. So in the interpretation of that, at least for the MACE outcome, was that the trial could not prove that tofacitinib was non-inferior to the TNF group in terms of MACE. And it also was subsequently the same for the malignancy outcome, that the upper limit was also above 1.8. So the end interpretation of the trial is that it did not prove non-inferiority of tofacitinib compared with TNF inhibitors on both of their endpoints, which were MACE and malignancy.
Thank you for that. And that was helpful, but I think that is a hard thing to message, certainly to patients. The trial was not non-inferior for MACE events or malignancy. But in fact, as we learned at ACR just recently, compared to patients who were randomized to the TNF therapy arm, either adalimumab, which was in the North American arm in the United States, or the rest of the world, which received etanercept, patients randomized to this tofacitinib arm had a 1.48-fold increased risk for malignancy, and it wasn't meaningfully different by tofacitinib dose, meaning that the rate of cancer was about the same for the 10 BID as the 5 BID. And that 1.48-fold increased risk for cancer was a statistically significant increased risk. So it's not just that it didn't meet its non-inferiority margin, it actually was significantly higher, which is not something anticipated by the trial and probably a surprise to many, I'm sure. So thinking about the implications of that, Alan, although it still perhaps remains to be seen, what do you think that the end result is going to be for the labeled indication for tofacitinib? Based upon what the FDA might do in the future, do you think that we in rheumatology will still be able to use it in patients that are inadequate responders to methotrexate before a first-line TNF as patients' first targeted therapy, or do you think that's going to go the way of the dinosaur?
Yeah, that's a really good question. Of course, we really don't know what the FDA label change may be. But as we all realize, that drug usage is often dictated not by patient or physician preference, but rather by the payer. And conceivably, changes in the FDA label may dictate to payers to change the sequence of the step edits that we're all accustomed to. And it'll be very interesting because obviously this is a very important class of drugs. And not only is it an important class of drugs, but it is one of the few potent oral alternatives that we have. So it will be interesting to see if they make an exception.
It will indeed. And I'm sure that alone would impact prescribing if nobody would pay for it based on the indication. So, Christina, thinking back to the trial's results, and you touched very briefly on the inclusion criteria, which was definitely not a standard RA population. How should we think about the generalizability of the study? And do you personally see the results as mainly only impactful for people who met the trial's inclusion criteria? Or do you think that some of the safety concerns raised extends more broadly to all RA patients?
Yeah, it's a great question. The trial design, as I mentioned, quite unique, specifically including only those active RA patients 50 years or older with an additional cardiovascular risk factor or more. This is the data we have. We don't have data in a different population group or groups. So I don't think we can project those results on different populations without having that granular specific data, or at least I'm not good enough to do it, Jeff.
Fair enough. Well, thinking about who the result does apply to, and maybe even more importantly, how we might apply these results to clinical practice. John, are there mechanisms that we need to think through about how to best do patient selection with respect to their cardiovascular risk? And do you use any of those routinely outside of a research context? And if not, how might that change what you might recommend others to do in the future?
Well, I think the data presented at the meeting did a really good job about defining what subgroups of RA patients seem to be most at risk. And so it did seem to be that for almost all of the outcomes that were of interest, including MACE, but also including malignancy and VTE, that older age was certainly one of the biggest risk factors, and patients greater than 65. seemed to be prominent. Also, people who had high cardiovascular risk for the MACE outcome, in particular, people who were current or former smokers. And the combination of smoking plus older age was, in particular, really one of the drivers for having cardiovascular events. So I think if we just start with simple demographics and cardiovascular risk factors, we can isolate a lot of the people for whom this risk was seen. Outside of that, there may be some other cardiovascular screening that can be done. I think that cardiovascular screening in RA is underutilized. And of course, identifying people who have atherosclerosis could help in those circumstances in which you're not sure, help to define people for whom perhaps a TNF inhibitor would be more beneficial to use than a JAK inhibitor. But I don't think we're at that point of recommending any particular cardiovascular screening outside of typical traditional risk factors and demographics.
Fair enough. So thinking then about how we should be applying that, if we're not doing lots of different or additional screening than we have been perhaps, how does this new data change how we should be using JAK therapies? Alan, what are your thoughts about that?
So that's obviously the big elephant that's in the room, so to speak, is how are folks like all of us going to be using this data to decide whether to use a JAK inhibitor, and will we still be using it in some cases before a TNF inhibitor as initial therapy after methotrexate non-responders. And it will be very interesting to see. I think it will have an impact, particularly on the first therapies after methotrexate non-responders. But it will also be interesting to see after they fail one of those agents, what our choice will be. I would like to bring up that one of the most interesting aspects that I found in the presentation was this number that they focused on, which is the number needed to harm. Which is a kind of a different way that we've looked at safety data. We were very much used to looking at incident rate ratios and such, but this is a very interesting way of presenting the data, and we'll see whether or not that adds to the discussion.
So that really then starts getting it down to practicality and how we might message this to patients. So if a number needed to harm of about 300 is what we might anticipate, I mean, that would mean that you would need to treat 300 extra patients for a year to cause one event, assuming that there really is a causal association. So that's a pretty high number, and I think many people would feel that's in a range that they're still comfortable with if a JAK inhibitor really seems to be a preferred therapy for a patient. But not everybody may agree on that, and safety is often in the eyes of the beholder. So what kind of recommendations would each of you give about how rheumatologists might message that to their patients? Is a difference of an event rate of 3 to 4 events per 1,000 patient years, is that clinically important? And how do we communicate that in an effective way to patients to participate in shared decision making?
Yeah, I'm happy to start, Jeff. I agree that the event rates were low and perhaps surprisingly low in this high-risk population. I think overall the data in the trial really did emphasize the importance of assessing baseline CV risk when we're treating our patients with RA. And when I see a patient, I tell them the results of the study very briefly so that they understand there may be some risk associated with certain therapies. And then we need to weigh those risks and benefits together. I think that's our job. It's going to be an individual on individual discussion as patients differ in their risk aversion, but that's how we can provide the best care and counsel appropriately.
Yeah, I also agree with that. I think that having the numbers from the different presentations is very, very helpful and allows us to put things into context. What we don't have is sort of what the overall risk for any of these outcomes is for any patients. What is my particular risk for having a cardiac event or a cancer or a VTE or any other thing? And I think that as we get more of the data, we can allow that context. But again, I think that the numbers are, the numbers needed to harm are actually very high, and that the blanket of don't use these drugs in anybody is too conservative, when these drugs are very, very helpful for many of our patients.
So what I do, and I think we all do this when we talk to our patients, is we bring the context of safety into the context of benefit for these drugs. And I think it's important that we stress that control of inflammation is very, very important. And that perhaps control of inflammation is a more important aspect of controlling risk for cancers or for cardiovascular events than sometimes more than the underlying safety of the drug. So that we really do need to focus on having good control of the disease if we want to control cardiovascular issues and malignancy.
And if I can just add to that, I think that the concept that you would take someone who is doing well on one of these drugs off of the medication and switch them to something else that might not do as well, especially if they failed a lot of things, is definitely the wrong approach to analyzing these data.
Yeah, no, I've heard anecdotally that some are doing that. And like you, I think that's probably a bad idea just because inflammation control and disease activity control really is important. I know in my own practice, I'll try to liken this for some patients to risks that they themselves might choose to take on. The risk of smoking probably exceeds drug-related risks, and yet people often feel very comfortable with assuming that risk and even continuing to smoke. So again, sometimes risks that are unmodifiable or related to a factor like a medicine loom larger than things that people live with every day, like tobacco use, for example. And yet sometimes those more modifiable risk factors get rather short shrift and don't enter people's consciousness or worry very much. So we're getting close to the end of time, but I would welcome from each of you any parting thoughts or wisdom about the way forward. Do we need more data? Is there any data forthcoming? Is this kind of what we're going to be left with? And just any final thoughts that you have to our rheumatology colleagues about how to think about the results of the study and how it might impact practice.
Yeah, I think, Jeff, the publications for oral surveillance are really going to provide us with even further granular data for review, including those risk factors and the specifics of the population that was studied. I anticipate that additional real-world studies, registries, et cetera, will also continue to evaluate the risk with all of our agents, including JAK inhibitors, and give us more useful information for clinicians and patients.
So I would like to see this, and getting back to the risk of being repetitive, of the number needed to harm, a way of approaching safety and communicating safety to patients. I really do think that it's a much better way of discussing this, particularly when events are very, very small. And I would like to see this expanded when we talk about safety for other drugs, and to start putting this into context so that we understand what a 300 number needed to harm number really means in the context of our clinical practice. So I would hope that this is a way of expanding that.
And there will be other data coming forward for other JAK inhibitors. There are other large safety trials that are enrolling right now. They won't have outputs for a number of years, but at least down the line, we'll have similar data, not exactly the same in terms of which outcomes were powered and which were secondary, but there will be additional data outside of tofacitinib in the future.
Well, thank you all again so much. And I think this very important study that took many by surprise, certainly myself included, compared to how it was designed, has caused, in some circles, a firestorm. From my own perspective, the incremental or additive risk of both cancer and MACE events put together still is less than 1% a year extra. And so when you put it in that context, or Alan with the number needed to harm, I think most people feel fairly comfortable that it's not zero and it's something that must enter discussion. But for the most part, it seems like all of you are comfortable continuing to use therapies in a thoughtful way and not just yanking everybody off wholesale or just continuing to abandon the class. So thank you again, and very excited to have been with you today and to think through some of these important issues as this data continues to evolve. Appreciate everybody in the audience who has interest to listen to this, and we all look forward to the publications coming out very soon. Thanks again.
Thanks, Jeff.
Thanks, Jeff.
Thanks, everybody.